Today we will be discussing about pulpotomy. As you all know, pulpotomy is a pediatric endodontic treatment modality. And which are the other pediatric endodontic treatment modalities? We have indirect pulp capping, direct pulp capping, and pulpectomy. So, what is the importance of doing all these pediatric endodontic procedures? The aim is to preserve the primary tooth until normal exfoliation. So, what will happen if primary teeth are lost earlier? If anterior teeth are lost earlier, it can affect the appearance of the child. It can affect phonetics, and also early loss can result in development of aberrant oral habits. And of course, both anterior and posterior teeth are important in mastication, and it can indirectly affect the overall health of the child. And in case of posterior teeth, in addition to the help in mastication, they also serve as natural space maintainers. When they are lost prematurely, the teeth on both sides can tilt and the opposing tooth can over-erupt, all resulting in disturbed occlusion. So the early loss of primary teeth can result in malocclusion in a child. So we come back to pulpotomy. As I told you, it is a pediatric endodontic treatment modality. We'll discuss about the definition of pulpotomy. It is defined as the complete removal of the coronal portion of the dental pulp, followed by placement of a suitable dressing or medicament that will promote healing and preserve the vitality of the tooth. So, what is the rationale behind pulpotomy? That is, the pulpal tissue adjacent to caries exposure contains microorganisms and shows signs of inflammation and degeneration. And when this tissue is removed, followed by appropriate treatment, it can preserve the vitality of the radicular pulp and the tooth can remain in an asymptomatic condition until normal exfoliation. The pulpotomy can be broadly classified into vital pulpotomy and non-vital pulpotomy. And in vital pulpotomy, there are 3 techniques, which in each technique, different medicaments are being used. Different medicaments or different techniques are being used. The first one is devitalization technique, where the pulp undergoes devitalization or fixation occurs, and the medicaments used in this group, examples are formocresol, then laser pulpotomy and electrosurgical pulpotomy. The second technique is preservation method, where there is minimal devitalization, but it is non-intrusive. That is, there is no formation of reparative dentine. And the medicaments coming under this group, examples are glutaraldehyde and ferric sulfate. And the third technique is called regeneration. It is inducive and reparative. That is, it results in formation of dentine bridge. And the examples of medicaments used in this group are calcium hydroxide, bone morphogenic protein, MTA, biodentine, etc. This technique is actually preferred in young permanent tooth pulpotomy. And the second broad category is non-vital pulpotomy, which is called as mortal pulpotomy. Here, in non-vital teeth, the treatment modality is pulpectomy, but when the patient is uncooperative or due to some other reason, we are not able to perform the elaborate pulpectomy. In such cases, the necrotic coronal pulp is removed and the infected radicular pulp is treated with strong antiseptic solutions like beechwood cresol for 2 to 3 weeks, and later on it is replaced by an antiseptic paste. So that is about the pulpotomy techniques. Now we come to the indications of pulpotomy. Pulpotomy is indicated in primary as well as young permanent tooth. And so it can be done when there is a large carious lesion or a mechanically exposed or an iatrogenic exposure. In all the cases, we assume that the inflammation is confined to the coronal pulp. So regarding pain history, there won't be any extreme pain. So the contraindications with any sign or symptom which suggests that the inflammation has extended beyond the coronal pulp into the root canals. For example, spontaneous pain, nocturnal pain, tenderness to percussion, gingival pathologic conditions like swelling or fistula, pus or serous exudate at the exposure site, and also pathologic mobility. And radiographically, you can, if there are signs of external root resorption or internal root resorption or periapical or interradicular radiolucency, all these suggest of irreversible damage, and hence they are not indications for pulpotomy. And another important contraindication for pulpotomy is when we open up the pulp and when we remove the coronal pulp, the hemorrhage from the amputation site should be controllable. We should be able to control bleeding in less than 5 minutes of cotton pellet pressure application. So, I think you got a brief idea about the indications and contraindications of pulpotomy. Now we will come to formocresol pulpotomy. Formocresol pulpotomy, as I told you earlier, it is a devitalization pulpotomy, and it is considered as the gold standard in pulpotomy with more than 80% of clinical success reported over the years. And this formocresol contains 19% formaldehyde, 35% cresol, and 15% glycerin, and the rest is water. And this formaldehyde, it reacts with the protein portion of the tissue and make it resistant to autolysis. And cresol potentiates the action of formaldehyde. And usually we use Buckley's formocresol, which is a 20% solution or a 1/5 dilution of formocresol. This formocresol pulpotomy was introduced by Sweet in 1930, and then it was a multi-visit procedure, and the current concept uses a 4 or a 5-minute application time, and even a 1-minute pulpotomy has been suggested by Garcia Gordon. Now we will discuss about the procedure of formocresol pulpotomy. So imagine there will be a deep carious lesion. So you give local anesthesia, isolate the tooth with rubber dam. All these superficial caries and debris are removed, and then the entire roof of the pulp chamber is removed using high-speed handpiece with water coolant. And then you will be able to visualize the coronal pulp tissue. The entire coronal pulp tissue is amputated using a sterile spoon excavator or a round burr, and then there will be bleeding, and this hemorrhage is controlled by using moistened cotton pellet moistened with saline, which is placed over the pulp stump. And then formocrosol is applied. While applying formocrosol, a cotton pellet is dampened with formocrosol. Then it is attached to absorbent gauze to remove the excess and is placed over the pulp stump for 4 to 5 minutes. After that, the cotton pellet containing formocrosol is removed, and the entire pulp chamber is filled with the material like zinc oxide eugenol. Here zinc oxide eugenol is placed, and this is the radiographic view after pulpotomy, over which a permanent restoration in the form of a full coverage restoration of stainless steel or aesthetic crowns are placed. This is actually a one-visit pulpotomy. You can also think of doing a two-visit pulpotomy. So where will we do that? All the indications for pulpotomy are met, but there is a sluggish bleeding even after the cotton pellet pressure application. In such cases, a moistened cotton with formocrosol is left in the pulp chamber. It is sealed with zinc oxide eugenol or a temporary filling, and after 7 days, the patient is recalled, and this formocrosol, this cavity is re-entered, and this formocrosol cotton pellet is removed, and the same filling with zinc oxide and the full coverage restoration is done. Why do we have to give a full coverage restoration? That is, after all the endodontic procedures, the tooth becomes brittle. This brittleness may be due to removal of excessive amount of tooth material, or there may be a change in physical property of the enamel and dentine following pulp removal. So what are the histologic changes that occurs when we apply formocrosol? When formocrosol is applied, the tissue, pulp tissue that comes in contact with formocrosol shows coagulation necrosis, and the pulp tissue seem to wall off this by forming a collagenous-like band. And 7 to 14 days later, 3 distinct zones appear. One is broad acidophilic zone of fixation. Second is broad pale staining zone with minimum cellular definition. And lastly, a broad zone of inflammation which merges with the normal pulpal tissue. And a gradual apical migration of these zones have been reported, and at the end of 1 year, only the zone of fixation will remain throughout the pulp tissue. Even though this formocrosol is considered as the gold standard in pulpotomy, it is a controversial material. systemic toxicity, antigenicity, mutagenicity, carcinogenicity, and permanent tooth hypoplasia are all being reported after the use of formocrosol. But recent research have shown that when used in doses typically employed for a vital pulpotomy procedure, there are no risks reported while using formocrosol. Because of these disadvantages, other materials like glutaraldehyde, MTA, biodentin all have been widely used as pulpotomy agents. Thank you.